Hey everyone, today we're diving deep into the nursing fundamentals of immobility. But first, I need you to completely rethink what bed rest means. It's not about resting, not at all. It's a highly unnatural state that can kick off this dangerous body-wide cascade of failures. So let's trace exactly how that happens.
Here's our game plan. We're going to start by mapping out the why, really understanding that domino effect of immobility. Then, we'll get into the assessment tools you need to spot danger early, and of course, the key interventions to stop it in its tracks. We'll wrap up with the absolutely crucial skills of therapeutic positioning and a quick-fire review of the most testable concepts.
All right, let's jump right into Section 1, the immobility cascade. Look, understanding the why, the pathophysiology, is everything in nursing. Knowing why immobility is such a threat is literally the first step to preventing all the nasty complications that can come with it.
This quote right here, this nails it. We are not talking about some passive state of recovery. We're talking about an active process of physical decline. It's called deconditioning syndrome, and you have to know that the clock starts ticking the second your patient stops moving.
I want you to think about it like a row of dominoes. One system failure directly knocks over the next one. So we're going to walk through this chain reaction, and we'll start where you always start, with your ABCs: airway, breathing, and circulation. That's the highest priority.
So, what's the very first domino to fall? It's almost always in the lungs. You see, when a patient is just lying flat, they can't take those big, deep breaths to expand their chest. Gravity takes over, and all that mucus just pools in the bottom of the lungs. This combo leads to something called atelectasis, basically the collapse of those tiny air sacs. And that swampy, mucus-filled environment, it is the perfect breeding ground for hypostatic pneumonia.
Next up, the cardiovascular system. You know, that pooled blood creates the absolute perfect storm for a deep vein thrombosis, a DVT. This is all explained by something called Virchow's triad. It's like a recipe for a blood clot. First, you've got blood stasis. The blood's not moving. Second, all that pressure can actually damage the vessel walls. And third, the body's own inflammatory response can cause hypercoagulability, making the blood thicker and way more likely to clot. Put those three together, and you've got a recipe for disaster.
And what about the muscles and bones? Well, here's a fun fact. Our flexor muscles, the ones that bend our joints, are naturally stronger than our extensors. So without movement to balance them out, those powerful calf muscles start to tighten, pulling the foot down into a pointed position. If you don't intervene, this becomes a permanent deformity called foot drop, and it can make it almost impossible for that person to ever walk normally again.
Okay, so we get the why now, right? We see the danger. So let's pivot to the how. How do we stop it? Section 2, your nursing assessment toolkit. This is where you, as the nurse, get ahead of the cascade. These tools are how you spot the specific risks long before they turn into full-blown emergencies.
First up, the Wells score. Now, this isn't about having a gut feeling. This is an objective, numbers-based tool that lets you quantify a patient's risk for a DVT. You assign points for specific things, like being stuck in bed or having that one tender spot on the calf. If that score is high, DVT prevention immediately becomes your top priority. No exceptions. Now, for a totally different kind of risk, we use a different tool, the Braden scale. This is your absolute go-to for figuring out the risk of skin breakdown and pressure injuries. A score of 18 or less is that magic number that tells you, hey, pay attention. But here's the pro tip, and the research backs this up. You have to pay extra close attention to the mobility and activity subscales. Deficits there are huge predictors of future skin damage.
And here is a number I want you to burn into your brain: 10 centimeters. It's so simple, but so critical. This is the official landmark for checking for a DVT. You measure 10 centimeters down from the middle of the kneecap on both legs, and you measure the calf circumference there every single day. Why? Because if one side starts getting bigger, that's called unilateral swelling. It's a classic objective sign that a blood clot is forming.
This brings us perfectly to Section 3, interventions to stop stasis. I mean, all that great assessment data is useless if you don't do anything with it, right? This is the so what part. This is the implementation phase of the nursing process where you take what you found and launch a proactive, life-saving prevention plan.
Let's start with a psychosocial one, because the mind suffers just as much as the body. You absolutely have to be able to tell the difference between delirium and depression. And here's the key, the onset. Delirium is acute, it's sudden, it comes and goes, and it almost always has a physical cause, like a nasty UTI or not enough oxygen. It is a medical emergency.
Depression, on the other hand, tends to be more gradual, more persistent.
So how do we fight back against that first domino atelectasis? With this little device, the incentive spirometer. This is a core nursing intervention. The steps are simple, but they have to be done right. Sit them up, get a nice tight seal with their mouth, inhale slowly and deeply to get that piston up, and then, this is key, hold it for 3 to 5 seconds. That's what pops open those tiny air sacs. Then exhale slowly. The goal is 10 times an hour, every hour they're awake.
And to stop those deadly blood clots, here are your DVT priorities. First, you're going to apply SCDs, those leg squeezers that mechanically pump the blood. But here's the #1 safety rule, and please never forget this. You never apply them to a leg where you already think there's a clot. You could break it loose and send it to the lungs. Always take them off once a shift to check the skin. And finally, teach your patient to exhale whenever they move or strain in bed. This prevents something called the Valsalva maneuver, which can put a dangerous strain on the heart.
Okay, on to Section 4, Therapeutic Positioning and Handling. This is so much more than just making a patient comfortable. Every single time you turn or move a patient, it is a prescribed therapeutic intervention. And it's got a dual purpose. It protects the patient's body, and it protects your own.
So here is the golden safety rule, 35 pounds. If you have to lift more than 35 pounds of a patient's weight by yourself, you stop. They are considered fully dependent, and you must use a mechanical lift. This isn't just a hospital policy. This is about preventing pressure injuries for them and preventing a career-ending back injury for you. Now for a very specialized technique, log rolling. You only use this for patients with a suspected or confirmed spinal injury. The goal here is perfection, perfect spinal alignment. The keys are a pillow between the knees to stop any twisting, arms crossed over the chest, and a team, usually 3 people, moving the patient as one solid single unit. There is absolutely zero room for error with this one.
And finally, let's talk about prone positioning. I want to be super clear. This is not about comfort. This is a powerful, life-saving therapy for patients in severe respiratory distress, like with ARDS. By flipping the patient onto their stomach, you're actually using gravity to your advantage. It helps reopen all those collapsed, fluid-filled alveoli in the back of the lungs, which can dramatically improve their breathing and get more oxygen into their blood.
And that brings us to our final section, the NCLEX Rapid Review. Whew, we have covered a lot of ground. So let's boil all of this down into the most high-yield, must-know points for your exams and, more importantly, for your clinical practice. All right, let's do a quick-fire review of the priorities. For respiratory, your job is to prevent atelectasis. For cardiovascular, you need to understand Virchow's triad and never, ever massage a leg with a suspected DVT. For safety, it's that 35-pound lift rule. And for psychosocial, you always treat acute confusion as a red flag for a physical problem until you can prove otherwise.
We'll end with one last question, a real-world scenario that traps a lot of new nurses. Your patient hasn't had a bowel movement in days. They're constipated. And then suddenly, they pass what looks like a small amount of diarrhea. So what do you think? Is this a good sign or a bad one? The answer is, it's a medical emergency. This is often pseudodiarrhea. It's liquid stool that's leaking around a hard, compacted stool. It is a classic sign of a severe bowel obstruction that needs immediate intervention. It's a crucial takeaway that will help you keep your patients safe.